This week on the BackTable podcast.
What we saw in a series of studies that we did and our colleagues did is that if we manage those retained products by hysteroscopy, we can really minimize the damage to the endometrium. And that's because, first of all, we don't do like a blind curettage. We put in a curette and take everything out, but we really do a more target surgery in the uterus. We just take out the part where it's attached, and we don't use electricity, so it's all like a blood surgery. And we saw that we could reduce those rates of adhesions from anywhere between 40%, 60% to around 5%. So it's a really huge deal.
Welcome back to another episode of BackTable OBGYN. This is your host, Mark Hoffman, and I've got a very special guest with us today. Someone I think is a phenomenal guest for our listeners, but also a very close friend of mine. And so we have Professor Noam Smorgick joining us all the way from Israel. Noam, how are you?
Good. How are you, Mark?
I'm good. It is so good to see you. And we shared a tiny office for so long, and I can say without any exaggeration, I don't see you enough.
For sure. Yeah.
For our listeners, Noam is the director of Minimally Invasive Gynecologic Surgery at the Shamir Hospital in Israel. Am I saying that correctly? Is that what it?
Pretty much.
Zarafit, I'm sorry. Associate professor at the Medical School of the University of Tel Aviv, or Tel Aviv University. So amazing that we get to do this from the other side of the world. And it's a gift to me personally, and hopefully our listeners enjoy it too. But Noam, you're going to come talk to us about intrauterine adhesions, hysteroscopic management of complex pathology. But as we like to do at the beginning of every episode, tell us a little bit about yourself. Tell the listeners sort of how you got to be where you are.
Well, first of all, thank you so much for having me here. It's really such a pleasure. I wasn't really meant to be a doctor. It wasn't something that I dreamed of. And I kind of thought I was going to end up like a philosophy professor or, something like in the more of a smart people job, like my mom. But somehow I ended up in medical school and kind of
with all the dum-dums.
Yeah, exactly. And really changed my life because I met my husband there. So it's kind of like weird to think where I might have been if I haven't gone to medical school, and then somehow ended up in OBGYN, which I really wasn't thinking about in the beginning. At first, during residency, again, I thought I was going to do like the smart people OBGYN, more of like fetal maternal medicine, that sort of thing. But I got completely hooked up by minimally invasive gynecology, sometimes during residency. And it's like from, the first time that I saw laparoscopy, I was like, this is what I want to do. This is the most amazing surgery, the most amazing patient that you can have the privilege to take care of. So really, I kind of stayed doing that for the last 20 years or so. I had really the such an amazing opportunity to the AGL fellowship in minimally invasive gynecology in Ann Arbor, Michigan, and this is where we were co-fellows with the really amazing mentors, Susie Asani, Arlie Song, and this is kind of where I learned a lot about, complex surgery, management of patients with endometriosis, chronic pelvic pain. And I'm kind of trying to keep up building my skills and my surgeries, kind of going into some new directions as well. So I'm kind of doing the same thing, but I still love it. I still think it's really the best job that I could have chosen. Even if it was by chance, it was still, so I still love it.
No, that's great to hear. I mean, I think a lot of us make decisions for ourselves at a younger age, whether it's to get, when you get into med school, you're like, oh, this will be fun. And then you realize I'm making a decision for myself in my 40s or 50s, but I'm in my 20s and I hope I have any idea what I'm doing. And so we've met people who have been less happy with their chosen professions. And it's tough. It's tough when you're in this job and you don't like it. So I love hearing that my friends are are happy. And ultimately, at the end of the day, your patients benefit from you enjoying your work, right? From being in a position to be able to enjoy your job. But I know we have a lot to talk about from the specific clinical stuff, but can you just tell us a little bit about your practice and what's different about how things were set up for us in Ann Arbor when we were fellows, and just, I guess how the Israeli healthcare system briefly works and how the academia works, because it's very different, I'm sure, and there's little nuances even hospital to hospital here. But talk to us a little bit about your practice, your job, your academic sort of setup, how it works over there.
Israel the health system is mostly a public health system. It's all managed through HMOs and public hospitals. So really most of the care is public. But there's also private healthcare through private insurance that actually a lot of people have. So the majority of my time is spent in the public hospital where we do surgeries and we have, the specialized clinics and so on. Most of the surgeons in Israel also work in the private hospitals. So kind of in your afternoons, evenings, weekends sometimes. So we kind of end up working, I would say, maybe longer hours compared to the US, but you have this kind of flexibility of doing the public healthcare and the private healthcare. In terms of academia, all the major hospitals are affiliated with a medical school. There are 5 medical schools in Israel. So we do have medical school students and we have university appointments, which you advance through research, publications, and so on. So that part, I think, is pretty similar. We do have, because it's a public health system, we have to manage a lot of our activities according to the cost. So we find ourselves really kind of having to figure out how much every new instruments cost. What's the cost of reusable instruments? What's the cost of non-reusable instruments? So we kind of have to figure out how we can make it work, because most of our surgeries are not reimbursed according to the actual cost. They're actually underpaid, I would say.
So similar to here, you perform a surgery, there's a cost to it. You send a bill to either a private, depending on which hospital you're at, a private insurer, or to the government, and you get some part of that back, right? So
Right.
It's interesting talking to John Solnick in Canada. They give you a check at the beginning of every year, the government does, based on the number of people you have that you're taking care of and the complexity, and that's it. And whatever you spend that year, you have to contain that cost. So where you and I don't know what your husband's doing these days, but I know as an orthopedic surgeon, for example, in the US, they bill like crazy at times, and it can be a financial engine of a hospital to have busy surgeons. In Canada, every surgery you do is pure cost. And so thinking of non-surgical, non-operative solutions can be very cost efficient and cost effective. So it, again, not providing any judgment or opinion, is just to see how the sort of the economics of healthcare can drive health outcomes and our interventions, sometimes more than the research or, our training. It's really like, what are our incentives? So I always ask when folks are doing things in different locations, how it works, because I don't know that there's a right way, or else we'd all be doing it. But I think there's certainly very interesting different approaches.
Right. Yeah, I do think that we have the option of offering more, I would say, conservative management options and not like going straight away to surgery. And like, I remember when I was in the US, there was always this concern of some of the patients that, I need a surgery, but I may or may not have an insurance next year. So I need to do it now because I don't know if I'll have that coverage in the future. And in Israel, we don't have that problem. You can have your hysterectomy now, in a year, in 2 years, you're always going to be covered. So it takes out,
even
I think,
year to
some
year,
of the
in the US,
pressure.
people have deductibles. So you have to pay a percentage depending on the type and quality of your insurance. And you have to pay this piece off before the insurance company will then give you any financial support for care. And so if they've already paid their deductible for the year, they want to squeeze in as much stuff as they can. Well, can you please get, December's busy because everybody wants to get the surgeries in before, the clock strikes midnight at the end of the year because then they got to start over and pay back into their deductible. So, yeah, right. I mean, again, it's driving healthcare in ways, and that's actually why I do what I do. That's why I'm interested in this work. It's not about like, because I like, sitting at my desk in my office, but it's because the way to impact care on a big scale, more so than anything I've ever seen, is really understanding how this stuff works from a financial perspective. But so we don't bore our audience to death talking about what I want to talk about, we should talk about what I think is really interesting, which is what you came here to share with us, which is complex hysteroscopic surgery for things like adhesions, septums, retained products. So I know you said you had just done some research at a recent publication. So tell us what that's about and tell us about how you got interested in this type of work.
Right. So I think the subject of intrauterine adhesions in Israel in particular is so important because we have a birth rate of around 3 children per family, even a little bit higher. And there are also some family of like Orthodox and Jews who have even larger families with like 6 or 7 or 8 children. So really maintaining fertility is something that's culturally very important to a lot of our patients. And we all know that adhesion, particularly if you have severe adhesions, can severely impact our patients' fertility. So we kind of have to deal a lot with prevention of adhesion. So how to do an intrauterine surgery without causing damage to the endometrium. And if we do have adhesions, how to treat them. So we kind of started thinking about this whole topic of adhesions, intrauterine adhesions, after we've started seeing a lot of adhesions in women who've had retained products of conception, which can happen either after a delivery. It could actually also be a delivery by cesarean section. There are also products after cesarean section, which is surprising, but we do see them. Or after pregnancy loss, which can be managed either surgically or medically. And we've seen that if we treat those retained products in a more, I would say, aggressive way, like with curettage, then we really see really high rates of adhesions, can be up to 60% of women, and they tend to be more severe. So the outcome, even if you do lyse them and you do hysteroscopic adhesiolysis, you still don't get very good fertility outcomes. And what we saw in a series of studies that we did and our colleagues did is that if we manage those retained products by hysteroscopy, we can really minimize the damage to the endometrium. And that's because, first of all, we don't do like a blind curettage. We kind of put in a curette and like take everything out, but we really do a more targeted surgery in the uterus. We just take out the part where it's attached, and we don't use electricity, so it's all like a blood surgery. And we saw that we could reduce those rates of adhesions from anywhere between 40%, 60% to around 5%. So it's a really huge deal.
So sharp DNC for retained products, adhesion rates are 40 to 60%.
Yeah.
Is that also the case with like a suction DNC with plastic? Because I know that we had talked about in fellowship. I mean, I remember even way back when, there was just no one was using sharp curettage for any sort of pregnancy-related DNC. But we use plastic cannulas, suction curettage. Is that also associated with an increased rate of adhesions?
Right. So that's a very good question, because the studies that we have on rates of adhesions are based on older studies where they did use a sharp curette, which is really like the worst thing for the endometrium. And it's probably low rates of adhesions when you do a suction curettage because it's more gentle, but it's still pretty high rates of adhesions. There are not a lot of comparative studies that you kind of compare hysteroscopy versus suction for retained products, just because they're kind of, especially in Israel, that would be pretty difficult to perform. But probably suction curettage is better than the sharp curette in those patients. So we kind of also did a study looking at the fertility rates after treatment for retained products. And again, we saw that we have some really good pregnancy rates for patients, about 80%, although they do tend to have recurrent retained products of conception after their next pregnancy. So even if you think, oh, I did a good job, there's no adhesion, the patient got pregnant really, really fast, there's still something that we cannot see that's damage in the endometrium that kind of makes the retained products kind of stuck there again. So after kind of doing all the studies on retained products, the next logical step was to think about how we manage those patients who have a pregnancy loss, the missed abortion. They can choose to have a medical management with misoprostol, but a lot of them actually prefer surgical management by either a manual section, or most people don't do them, but a curettage. And what we know from a very interesting study from the Netherlands, that actually the surgical management by suction curettage of patients with a missed abortion can end up causing adhesions in about 30% of patients, which is, I think, it's amazing.
Is it MVA?
Yeah, with an MVA.
30%, really?
30% rates of adhesions.
And I would imagine that would be analogous to like a suction DNC that we're doing now with plastic curettes, right? That's just a different mode of suction. I would think that MVA would be less traumatic. Again, this is purely just my opinion, but that seems to be what would be more, I think, similar to what we're doing with suction. But 30% really for an MVA.
Yeah. So it's a really interesting study done by a group of doctors from the Netherlands. They actually did really a fantastic study looking at women with early missed abortion, first trimester pregnancy loss. Half of them were managed with just regular suction, and the other half were managed by suction. And then what they did was put inside the uterus an anti-adhesion barrier gel, which is usually made of zinc acid. And what they saw was that they could reduce the rates of adhesions from 30% in the control group, the ones who've just had the suction curettage, to about 12% just by using the gel. So really interesting study. And what we, and actually other people as well, thought that, so if the rates of adhesions is so high just by doing a suction curettage, maybe we can do it better surgically. So instead of just doing the suction, which is again a blind procedure, maybe we can do the whole thing by hysteroscopy, kind of similar rationale to the management of retained products. So you put it in your hysteroscope, you see where the gestational stack is attached to the endometrium, and you can just separate it very gently and take it out. So there have been a couple of studies which were really more of like a pilot study. So just looking at feasibility, kind of seeing whether this is a procedure that is doable, that you can have a good view inside the uterus, that you don't have a lot of bleeding. And there are a couple of studies that actually showed that this was a feasible study. And what we did was randomized controlled trials. So really comparing those women with early pregnancy loss. Half of them underwent just a regular suction MVA, and the other half we did a hysteroscopy using the tissue removal device, which is, again, not something that we were the first to pick up, but this was the first comparative study that really compared those two techniques.
Is this a hysteroscopic morcellator? We're talking about MyoSure or other analogous devices?
So actually what we saw is that, I think quite surprisingly, we could complete the hysteroscopy in almost all of the patients, about the 96%. So it's doable, it's feasible. It's not a simple hysteroscopy. It's more difficult than just picking out a polyp or something like that, but it is doable. And we saw that we had
Is dilating different at all? I mean...
So we used the small diameter trochlear, which is 6.25 millimeters. So you can actually do a vaginoscopic insertion. You don't actually need to dilate in a lot of the patient, which is, I think, another advantage.
And these are done in the OR, not
right. So for this study, we did all of them in the OR just because it was like a new procedure. You don't want to have the patient wake when you're not sure exactly how you're gonna handle this. I think the next step is maybe thinking about doing this in like a procedure room and not in the OR, and maybe, under sedation and not exactly anesthesia. So we can tweak it up a little bit more, I think. But the main result that we were interested to see is that we have really minimal rates of adhesions after doing the hysteroscopy. We just had 2 patients with adhesions. And in the suction group, we had about 40% of patients with adhesions. I do have to say that most of those adhesions are mild. which is to say we're not sure how they're actually going to affect fertility and future pregnancies, but you do see them when you do like a follow-up of hysteroscopy. You do see those adhesions, as opposed to a really nice endometrial lining, like, completely normal when you do the follow-up after hysteroscopy.
So still pretty high.
Still pretty high, yeah.
Is it qualitatively different? You said it was like mild, but I guess we hadn't really talked about what the adhesion rates are for like an MVA. Is it similar to an MVA now? Or hysteroscopic removal of products in terms of its rate of making adhesions, is it comparable to MVA?
So I think after an MVA, you're going to see more adhesions than after hysteroscopy. I'm pretty sure of that.
So have you guys changed your practice now to that being the standard way of doing it, or is it still a work in progress?
Good question. So it's still work in progress because there are some obvious downsides to doing the hysteroscopy. First of all, it takes much longer than just an MVA. MVA would, it's like a couple of minutes, whereas hysteroscopy is certainly longer. There's the issue of cost, like we talk, for the trocar, you have disposable instrument that you need to use for the, just a section. It's very cheap. There is the issue of having, a trained surgeon that is able to do the hysteroscopy as opposed to the section, which is a very, routine and easy procedure. So there are definitely downsides. And I think once we kind of have our data, we'll end up by using this procedure for subgroup of patients who are at risk for adhesions. For example, patients with infertility, patients who've had recurrent abortions, or, maybe they're undergoing IVF or something like that. So I think in the end, it's not going to replace suction for those patients with pregnancy loss, but it's going to be targeted for a specific subgroup of patients. So we'll see. In that regard, actually, one of the advantages of hysteroscopy that we haven't really looked at in this study was if you have a patient with recurrent pregnancy loss and you do a hysteroscopy to take care of that, you also have the options of looking at the embryo, maybe even diagnosing some of the fetal anomalies that could be associated with the pregnancy loss. And you can also obtain a genetic tissue diagnosis of the embryo to kind of look for reasons for pregnancy loss. And this is something that is being done by Charles Miller in Chicago. Yeah, again, in a subgroup of patients with infertility, IVF, because this is kind of the way that it is practiced.
So hysteroscopy on pregnant patients.
Yeah, on with pregnancy loss.
We'll have to get Chuck back. We had Chuck on the show probably last year. We'll have to get him back on the show to talk about that one.
So this is now his like a pet project.
He's so good at that, at finding the next thing.
Yeah.
And like being
he's very excited about it.
Being an innovator on things. But yeah, wonderful.
Yeah. So I think this is kind of where we're going to go, because we're going to have this option of not only taking care of the uterus, of the preventing adhesions, but also having some additional tests to kind of figure out why has this pregnancy loss even occurred? Is there like a genetic reason? Is there something else that we can do to prevent pregnancy loss in the next pregnancy? Which now at this point, we don't really know how to prevent it. So this is kind of something that's going to happen in the future.
Is infertility treatment covered in Israel?
Yeah. So infertility treatments, including IVF, is covered up to 2 children. Yeah. So it is covered. I think Israel is probably one of the countries with the highest rates of infertility treatments. Yeah. So we have a lot of patients actually with infertility that we take care of.
Why do you think that? Are the rates of infertility higher there? Or are people waiting later to have kids? What's the thought behind infertility rates?
Probably infertility rates are not different, but just people are not going to wait like a whole year before they have a child.
Covered. Let's do it.
Exactly.
Interesting.
Exactly. Yeah. So we do treat a lot of patients with different kinds of infertility.
Are you treating infertility in your practice at all? Is that part of what you do as well? Or is that just something done at your hospital?
Right. I don't do fertility treatments. Personally, I don't have training for that. But we work very closely with our infertility doctors. So we have a lot of referrals for patients with, endometriosis, uterine anomalies, problems, fibroids, like all the different problems that can associate with infertility.
Yeah, I was asked to give a lecture to our nearby medical school's REI fellowship about surgery and sort of impacts or benefits of surgery regarding sort of reproductive issues. And there's not a ton out there. There's not a ton like, myomectomies if it's in the cavity, but otherwise like sort of trends, but it's not clear. Endometriosis surgery, like unless you're specifically unblocking fallopian tubes. I mean, infertility we know is impacted by endometriosis, but does removing it help? And the data is not great. One area where I think there is pretty good data though is intrauterine adhesions and things, but also on the other side, one issue that you and I talked about previously was things like uterine septums. Can you talk to us a little bit about sort of how you address uterine septums and adhesions as they relate to infertility and sort of what treatment options there are and how you prevent or at least try to decrease the rate of recurrence?
Right. So I think the management of the septum is really one of the really most interesting kind of like stories in our practice, because we kind of have this huge shift from what we were doing a few years ago to what we're doing now. Again, it kind of shows that when you have like different type of studies, it can really change the way you think. And I think really the septum is one of the examples of how things have shifted. So as you know, the studies that we had until a few years ago, they were all retrospective studies that kind of compared the pregnancy rates and the abortion rate of patients with septum, kind of the before and after design. So they had patients with recurrent pregnancy loss. They were diagnosed with the septum, removed the septum, and then they saw that they had just higher rates of live birth. So studies with retrospective methodology. And then we had, again, the group from the Netherlands that did a randomized controlled trial called the TRUST study. What they showed in the study was that removal of the septum does not improve rates of abortion, live pregnancy rates, and so on. So the study was criticized because they did have some problems with recruitment of patients for sure, with how septum is diagnosed, because as you know, there are different classification of septum from different societies, and it kind of changed over the years of the study as well. So it wasn't really homogeneous in terms of diagnosis. So again, the study was criticized, but now we kind of have to deal with those opposing results. On one hand, the older studies that show that septum does have an impact on abortions and fertility, and on the other hand, this prospective study that showed that maybe doesn't. So it kind of puts us in a weird place where, we have a patient, they were diagnosed with the septum, and, they come to see us and are like, what should we do? Should we go and have a surgery or not? And kind of the way that we are supposed to manage it is the shared decision process with the patient. But, ultimately the patient, I'm sure it happens to you too, the patient just come back and tell you, doctor, you're the doctor, just tell me what to do.
There's that, or like, this is what I want, even
Right.
though we don't know anything, or we do know we shouldn't do it, and they still want it, right? So it's all of those things, right? And you said it nicely, shared decision making. I think when you first start out, you think you know all the answers, and you find out very quickly how little you know, and then at the end of the day, you realize you're talking to another adult. You can, trust that your communication is good enough, they understand it, and let them make a decision that's within reason, I think is sort of how my practice has progressed over time. But yeah, that's one to get not infrequently is, hey, I've got a septum, right? We have infertility. Septoplasties are cool. I mean, they're kind of fun when you're done, and there it is, and then there it's not. But are we helping? I mean, again, I think the data is not great. I think in the US, we tend to think it's probably not helping, and over there, we think it probably is. I'm trying to remember, one of the fertility societies says one thing, the other says the other. But routinely, are you doing them pretty routinely, though? Is that something you are taking care of over there?
Right. So we kind of try to kind of find the kind of the reasonable way between the kind of not do anything and kind of do the surgery for patients that we think there's an indication. So what we kind of tend to do, if we have a patient with recurrent abortions and they have a septum, if we have a patient with infertility and she's doing IVF and it's not working, we think that it's reasonable to offer surgery in those cases. On the other hand, I would hesitate to do surgery for a patient who's asymptomatic. She hasn't even tried to get pregnant. I would hesitate.
And I think that's kind of how I approach a lot of things that we do, right? Like possible endometriosis, very clear we're not saying you don't have it. Very clear we believe you're in pain and it's a possibility. But, optimizing medical management is, I try to make sure we at least try some things, because I think the data that I've seen is that we should be on something. Patients should be on something. But some folks are so quick to just operate first and, answer questions later. I think there's something that, again, not right or wrong. It's just we develop practice patterns based on a number of different things over time. But yeah, I think that's something that they have known for infertility. You've kind of done the other stuff. One other thing here is that, if you're going to spend 20, 30 grand on IVF, like, is it unreasonable to do the covered surgical procedure, septoplasty or myomectomy and other things that might improve your likelihood in theory, knowing that this is not a cheap intervention that you're going to have to pay out of pocket in most U.S. states. Some certainly it's covered. Chicago, where I trained in residency. Other places like Michigan now covers it for their employees, IVF, but it's not a state mandate. So it varies. So how we practice is very dependent upon what your patient's options are.
Right. And also, you need to take into consideration their age, if they're like on the older spectrum of fertility, she may not have the time to wait for kind of see what's going to happen.
Yeah, see how it goes and come back. And it may be too late for some folks. Yeah, for sure.
Exactly. So, again, this is where kind of the shared decision-making comes into play, that we kind of have to think about the specific patient and kind of think about what's best for her. And again, taking into account, like you said, that metroplasty is actually, it's a pretty straightforward surgery, low risk, very fast recovery. So sometimes we just think, maybe I'm not going to help her that much, but at least I'm not going to cause a lot of damage.
Assuming you're just using cold scissors for most metroplasties. I'm saying septoplasties, but thank you, metroplasty.
Right. So it kind of depends on the length of the septum, because if you have a pretty long septum, sometimes it would be easier to use electrosurgical energy like bipolar needle, or the mini resectoscope with the hook, which is also, I think, a really nice new instrument that we have. And then after you've done like I would say probably like 80% of the septum, then kind of like tweak the side that's closer to the fundus of the uterine with the scissors. Again, especially when you do a metroplasty for bigger septum, you have to think about adhesion prevention, like using an intrauterine adhesion prevention gel and doing the follow-up hysteroscopy.
Are you doing routine injection of gel, of the hyaluronic acid gel for adhesion prevention? Is that something you're doing pretty standard?
Yeah, actually, I try to use them as much as I can. Again, the main issue would be cost, because it's like an additional product that we need to use during surgery, and you don't get specific reimbursement for that. It's kind of like all in this package of how much you end up spending for the surgery. And
what's the perceived reduction in risk of adhesion formation with that? You said it was about half, I think, before.
So specifically for the intrauterine gel, I don't know that there are any very good studies that show the reduction, but this is kind of where my personal experience comes into, and I do think that I see a difference in the rates of adhesions and the severity of adhesions with the gel. And again, it's something that I know is not going to cause any damage. So, if I do have it available and I can use it, and again, it's in Israel, it's all part of the cost of the surgery. The patient doesn't have to pay extra for the use of the gel. So, if I have it, I think it could be helpful, when I use it.
Is there a risk of infection, putting some new possible, introducing some new thing into the uterus? I guess you don't worry about, the evidence suggests that it does not increase your risk of infection.
I haven't seen a higher risk of infection for using the gel.
What about estrogen? Is that something that, I know that was something that, Foley balloons, things that they've done in the past. Data I don't remember the data being great for that. What's your understanding of the data for those other interventions?
So for estrogen, there are actually not a lot of studies. There are actually a fair number of new studies coming out of China on adhesions prevention and adhesions treatment. But specifically for estrogen, there's not a lot of data. But again, my personal experience is that I do think that it's has a role in regenerating the endometrium. So I do like to use it. You actually use a pretty low dose of like 2 milligrams of estrogen. So, it's not something that is going to cause any damage. And
just oral, PO estrogen.
Just oral, yeah.
And how long are you giving it for?
For like 3 weeks.
Okay.
Yeah. And then you just do follow-up office hysteroscopy.
Do that standard? I mean, office hysteroscopy, for everybody you do these procedures on, you're always going back to look 100% of the time?
So we do the follow-up office hysteroscopy for the procedure that are at higher risk for adhesions. This is kind of the standard practice. So it could be either removal of routine products or metroplasty, or if you have like a multiple myomectomy. So all the hysteroscopic surgeries that are at risk for adhesions, actually the best way to manage adhesions is when you treat them early, because interestingly, adhesions are a dynamic process. So they tend up to be milder when you treat them soon. So for after like 6 weeks after the surgery.
I can see that. I mean, I think about, if you ever have to go back soon after laparoscopy, like I did a hysterectomy recently after someone had a previous other non-related surgery, but you go, okay, the little filmy stuff, and you can just kind of sweep it away. And again, I have to use your imagination, but you can see how those things have just left there over time could certainly continue to cause trouble and progress. And certainly in a dynamic cavity like the intrauterine space, I mean, as there's constant inflammation and sloughing and all those things happening, I can see it makes perfect sense. What's your hysteroscopic setup in the office?
So for the office, we just have like basically it's like a office procedure room where you have your hysteroscopy tower,
So is it rigid or flexible?
Oh, it's all rigid. Yeah, we don't actually use a flexible at all. We do have the use of NO gas.
Nitrous oxide.
Right, nitrous oxide is for
laughing gas,
analgesia and so on. We don't use any like IV sedations or what have you.
Something for most patients, or most patients just come in and you take a look?
Most patients are not going to need, any sedations or
Have
anything.
you ever used any of the disposable devices like EndoC or those other? Have you ever tried those?
Right. So EndoC is notoriously expensive. So So I just brought like the rest just brought a couple so that we can like try them on. But it's not something that we have that we can buy routinely.
It's amazing how different it can be. But for us, all of our reusables have to be processed through central sterile. So, and our clinic across the street has to get sent over to the central sterile across the street to the hospital. So you're not going to be able to do more than 1.5 day. Each half day. So you can do 2 a day, which if you have one scope, right? So if you have multiple scopes, that's fine, but you're not able to use, you're not able to sterilize them or clean them in the office. And there's no hood, and we try to get it, but it's all, so I think for a lot of us, it becomes a challenge. And so finding a disposable, even though cost is actually not as bad as I thought, but just the waste, right? Like just throwing one away every single time. It's amazing. I mean, the scopes they use for GI stuff or respiratory, all the different, a lot of those folks are going 100% disposable just because it's actually relatively price neutral, but they're easy to access. They're always available, always clean, and it frees up sterilization room resources for other things. And so there's all these operational efficiencies with it and stuff, but it's just so much waste, so much trash.
Right. Like you said, actually reusable does not mean that it's without cost, because the whole process of sterilization is also expensive. But, we have 15 optics and so on that we can just use, for
That's
for a
great.
whole day of office hysteroscopy.
Super
and
jealous.
we just reused them, I don't know how many times.
No, it's amazing. I remember when we were in Ann Arbor, we had those 3 flexible scopes, and you could just go
Right.
one after. I mean, it was just next one after the other. It was like, this is the most fun I could possibly have
Right.
at clinic. I mean, just like boom, 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 and patients didn't feel a thing because you could drive it in. You could, it's flexible, so you could steer it in without touching anything, and it was patients really preferred that to other options. But yeah, anyway, no, it's interesting. I think about, a lot of the clinical decisions we make are not strictly based on what's best because we don't always have data. But if you're in a busy practice, whether you have a ton of OB or whether you're in a practice that has limited access to certain things like operative diagnostic hysteroscopy, whether it's reusable or not, like you're just not, if it means going to the OR again, well, then we're not going to go to the OR and do another case if there's not really good data to say we need to. So if it's very easy, I think it makes sense. But is the choice to do routine post-op office hysteroscopy based on, or I guess what evidence are you using to base that decision, or just because you do it a bunch, that you see it quite a bit and it's good to go in there and just make sure it's not going to be a problem?
Actually, so kind of like our rationale for doing postoperative office hysteroscopy after procedures that are at high risk for adhesions is something that's kind of the routine recommendation of the hysteroscopic societies. So it's not something that we kind of thought of in my practice. And I do think it makes sense, like we discussed, to kind of take care of adhesions before they become fibrotic and dense. And again, I kind of think it depends on what your patient's wish is for fertility. Because, if it's a patient who has, I don't know, maybe has like 2 or 3 kids and, she's like, I'm not thinking of having another pregnancy, I just want to put in, I don't know, an IUD or something, then obviously you're not going to go ahead and just do a checkup. But if it's a patient who does have an interest in having another pregnancy, then I think it's something that we need to do.
Well, that's great. Are you doing much operative hysteroscopy in the office? So like little polyps and things, or is it almost all being done in the OR?
No, actually, we have the option of doing operative hysteroscopy for like different pathologies. So polyps, actually, if you can use the tissue removal device, you end up by having the option of taking larger polyps in the office, because once you have your trochlear inside the cavity, you can just take out pretty much everything, right? You can take out a big polyp, small polyp.
Is there a manual one, or is it just the one the regular one?
No, just the regular one.
Powered.
Just the regular one, because it's so fast that you can really take out larger polyp instead of ending them with scissor, which
Which I do, and again, as an administrator now, I'm like, oh no, we don't have to pull out that big giant thing and all that cost, and I'm snipping away, going, it would be so fast, and I don't think the outcome is better. I wouldn't use scissors if I didn't think we were getting a similar clinical outcome. I wouldn't expose our patients to those issues, but teaching and those things, like it's just like it would be faster, and if I felt like there's any reason for patient care to do it, I would always do what's best. But they're comparable. Sometimes it's just nice to go and just suck it out and we're done. It takes no time, and yes, it is nicer, but those are the things that we have to think about. I'd rather save money on stuff than people. And sometimes, I think we think about, as healthcare changes in this country certainly are going to make it a little bit tougher. These are the kinds of things we have to think, how do we be really lean? How do we be really thoughtful about how we do it, but not restrictive in what we offer patients? And so it's a balance. But I always find it interesting to see how different, not even just different countries, but just different practices are set up. And it really can drive how you provide care. But it sounds like you guys are doing amazing stuff over there.
Yeah, I don't think we kind of, we didn't really invent anything new, but yeah.
Well, no, but I mean, again, creating the process and building the teams is as much a part of getting people what they need than just knowing the right thing to do, right? Like we can, I've been lucky, maybe is the wrong word, but lucky enough to work in some very, very, very under-resourced clinics and hospitals, and you go, wait, this is like, I mean, I know the answer, I just can't get them that thing, or I can't get the patient here, or, it really is, so much of it is of getting patients the right care is not guessing the right answer on a multiple choice. It's like all the things that have to move to allow us to do these jobs. And so obviously that's how my brain works. And that's how it's like, it's probably how it's always worked, but that's how it has to work a lot more these days. But it does drive the care we can provide. So what are other things you're doing over there in terms of intrauterine adhesion management? Is that for the most part, see it, treat it, follow up, and then in terms of additional follow-up after that, or any medications, anything else you're doing, or is it more or less go back to your fertility doc and let me know what else you need?
Right. So after you've cleared the adhesions and you have your follow-up and you see that you have a normal cavity, no adhesions, nice lining, then there's really no further follow-up that you need in terms of the hysteroscopy part. Then, the patient can either go back to fertility treatment or just try for a spontaneous conception. So that's the nice thing about adhesion. It's basically, once you've treated them, you have a normal follow-up, you're done. So it's very satisfying.
Somebody else's problem.
Well, I hope they don't have a problem
That's
anymore.
Right.
So
that's right. You fixed it.
them.
That's
yeah.
Right. Well, good.
Yeah.
What's the future look like for this stuff? I mean, are there things on the horizon we should be looking out for? Are there things we should be thinking about, whether it's building our practice or different interventions or instruments that are sort of the new way of doing things? Are there things you think we will be doing differently in the future?
So I think hysteroscopy is really one of the topics in our practice that has changed the most kind of like in the last 10 years. We have so many new instruments that really open up so many possibilities for doing minimally invasive surgery. So first of all, the tissue removal device that are getting smaller and smaller. And we can kind of visualize the point where we're talking about diameter of maybe like 3 or 4 millimeters, that you can really use them without anesthesia and really taking care of a lot of pathology very easily. As you also know, it's a lot more easier for the surgeon, shorter learning curve. You can really have residents kind of learn how to use them really quickly, as opposed to the resectoscope working with the electrosurgical loop, it's more difficult for sure.
No, there's absolutely a learning curve with that. And it's one of those things with the resectoscope, because it's not just the hysteroscope, because you have the hysteroscope, which you can rotate. You have the scope itself, or the camera that you can rotate, the scope that you can rotate with the light. You have the device itself, which rotates all independently, and the depth of the camera and the resectoscope or the hysteroscopic morcellator all happening at the same time, right? And so you have to just sort of decide and see it in 3D, and, if the pathology is there, do we bring the camera the other way, and do we, flip it around? And those are the kinds of things that I think a lot of people don't. It takes doing a lot of these.
It does.
And it takes, getting good. Oh, it's just hysteroscopy. There's no. Like, there's no such thing as just hysteroscopy. There's absolutely it is a procedure with, I think, a real learning curve, and one where, especially operative hysteroscopy, where you see it, if you don't do a lot of these, it can become tough to get good at it. Certainly it was for me, but something I enjoy doing as much as anything else in my practice is operative hysteroscopy.
So I think, again, the kind of moving into smaller and smaller instruments is going to be something that's going to change the way that we do hysteroscopy even more. We have new instruments like the mini resectoscope, again, which I think is really a wonderful invention. Really,
and that's
it's
one.
amazing.
I don't have a resectoscope in my hospital.
Yeah, so it's basically the resectoscope with a diameter of 5 millimeters. So obviously it's not going to be helpful to taking out like big pathologies like big fibroids, but for taking out small pathologies, working in the smaller areas of like the tubulostia, where it's sometimes a little bit more difficult to getting the tissue removal device. So we have kind of this different instruments that we can use and kind of see what's best for each procedure, for each patient, in the OR, in the procedure room. I think it's amazing to see how those newer instruments are kind of changing the way that we work.
Are you doing much much fibroid ablation, the transcervical fibroablation?
Right. So we actually just started because it wasn't available in Israel until last year. So I actually just started doing them. I think it's going to work great.
I think it's fantastic. I've been watching it for like a decade from when I was on the ACOG coding committee. It's those fibroids that are like, they're intramural, they're going to grow. I don't need to do a necessarily need to do a big myomectomy for this 2 to 4 centimeter fibroid that's really minimally impacting. They're symptomatic, but it's like, but now we can go in and go bzz and kill them so they stop growing. Because it's going to be 4, 6, 8 centimeters, at some point down the road, potentially. And it's like a way to, those ones in the middle, those ones that weren't quite big enough to go after, but by the time they get big enough to go after, it can make the surgery very different. So that's sort of how I see it. It sort of fills that clinical gap for me, or that interventional gap for me. Those ones are like, well, patients don't really want to do a laparoscopic myomectomy, but they are symptomatic and don't want to do nothing for these fibroids.
Yeah, no, I agree. I don't have a lot of personal experience at this point because we're just starting doing them. But again, I think that it offers up a lot of potential for those patients who kind of are in the middle with their fibroids.
Yeah, I was the first in Kentucky, and I'd done the most here for a little while. Obviously those numbers have gone down a little bit as I've become a little less clinically active, but my partners are doing a bunch. And I do think there is a significant learning curve with that too. I'm not sure how much ultrasound you read, but I read 30 to 50 scans a week, and that's transvaginal, not transuterine. I think there is a learning curve with that too. I think it's a great device, but yeah, I mean, as we evolve, there's just so many more things we can do, even since way back when you and I trained, which wasn't that long ago. Feels like it wasn't that long ago, but it does. Some days it feels a long, long time ago. Are you going to go to Vancouver this year?
Yes.
Which way do you go? How do you get there?
So I'm going to go through New York. And then,
okay.
Yeah.
Are you going to take any extra time, or?
I'm going to take
It's
like
a long
day.
trip.
Yeah, it is. Yeah. And I hate long flights.
Well, that's going to be at least 2 of them each way.
Yeah, exactly.
What's the time for Tel Aviv to New York?
Like 11 hours. Yeah.
So, I mean, I've been to Israel. I've been to Europe a few times, and I've been to Australia. But I can tell you, sitting in a coach seat when I was younger, it was no fun, but it was fine. And we just went to go to London to see my brother's band play with the kids, and I hadn't been overseas in a while. And that coach flight, I was like, oh man, I'm feeling it. I am.
Yes.
And I'm not in a position to pony up for first class or anything, but man, it feels different. Let me just say, it feels a little less fun for these longer flights. So I'm actually looking at Vancouver right now, thinking, I'm going. I'll be there for sure, and look forward to seeing you and everybody else. But one of those flights, you're just like, man, it is far away. Vancouver's a lovely city. It's one of my favorite cities in the world. The food is amazing. Like, so much of it is just like, it's worth the trip, age aside. But it's a long flight, and I'll be thinking of you as I complain about my flight. I'm like, oh, at least I'm not at least I'm not doing this flight on the back of a 11-hour Tel Aviv to New York flight. So, well, I know that we are all so grateful that you're doing all that to get over to see us, because it is such a gift to see you in person. And it was a gift today to get to see you and catch up with you. And again, give my love to your family. I'll have to find a time to get everybody together one of these days. But I love seeing all the things you're doing and hearing about it. And it was so much fun. Thanks for making the effort to make it work with it. What is it now? 10 o'clock at night there right now? What time is it?
Yeah, it was perfect time. Saturday night, perfect time. Yeah.
Saturday night. What else you got going on except putting on some headphones and talking to your old buddy?
It was so much fun, really.
Well, no, that was such a pleasure. So thank you so much. And
it was.
We'll have to find something else. I know you're doing a million things, so we'll have no problem finding something else. We'll get you back on, and we'll see you in November.
Great.
Thank you so much for listening. If you haven't already, make sure to follow the podcast, rate it 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable OBGYN on Instagram, Twitter, or LinkedIn. BackTable OBGYN is hosted by myself, Mark Hoffman,
and Amy Park.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe D'Agrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon Hess and Yvonne Orgodzinsky.
Show notes and social media by
Emma Landenwich
and Lindsay Beecham.
Administrative support provided by Judy Dela Cruz.
Music written and performed by Scott Baby Daddy Hoffman.
Thanks for listening, and we'll see you again next time. The views and opinions expressed by the hosts and guests on BackTable OBGYN are their own and do not reflect the views or positions of their employers